Hello to all and welcome to week 5 of IOM 1120. This week we are going to look at the ear and the eye. As always, please get the notes available for you to reference during this lecture. So first we're going to look at ear anatomy, and all parts of the ear are associated or lie within the temporal bone. The external ear, which is labeled here as the outer ear, funnels air vibrations towards the middle ear. As you can see, the middle ear is labeled here. The middle ear is a cavity within the temporal bone, and it contains the ear ossicles, which are the stapes, incus, and malleus. These bones conduct vibrations from the tympanic membrane to the internal ear. So the tympanic membrane is labeled eardrum, and then of course they're going to conduct to the inner ear, which is labeled here. The mastoid air cells and the tube are continuous with the tympanic cavity. The internal ear consists of a convoluted tube, which is known as the membranous labyrinth, in which the receptors for hearing and balance are housed. The membranous labyrinth itself is encased in a bony chamber called the osseous labyrinth, and we'll look at this in more detail. In this picture, you can see we have the cochlear here and the semicircular canals. So when we look at the anatomy of the ear, the external or the outer ear consists of the ear itself, which is known as the pinna, the external auditory meatus, which is going to be the hole into the ear. You have the ear canal, and then it does include the tympanic membrane here. These three components make the outer ear. The middle ear, of course, has those ear ossicles, which include the stapes, the incus, and the malleus. It also includes the nasopharynx, which is the tube here. You may hear it called nasopharynx or eustachian tube. That's the same thing. The ossicles, and then the mastoid air cells, which you can see are these holes in the bone that you see in the middle ear. The inner ear, of course, we have the cochlea, the semicircular canals, and the internal auditory meatus as well. Note that the vestibular nerve and the facial nerve and the auditory nerve all come together outside of the inner ear. They actually do not pass through the middle ear, and we'll look at that in more detail here shortly. The external auditory meatus is S-shaped in adults, and it's straighter in infants, so please note that. The outside is made of cartilage, and the inside is made of bone. Of course, for more information on the ear anatomy, reference Gray's 902 and 903 and Netter's 92. So now we're going to talk about the tympanic membrane. The tympanic membrane is considered part of the external ear. For more information on it, you can reference Gray's 09 and Netter's 93. The tympanic membrane separates the external ear from the middle ear. It consists of a central fibrous core that you can see here, which is interposed between a thin layer of skin on the side of the external meatus, and then you have a mucus side on the tympanic cavity. At the center, it is attached to the handle of the malleus, which is an ossicle. At this attachment, the umbo, which means knob, is the membrane. It's drawn inward and is cone shaped. So you can see the umbo here, Above the umbo is the lateral process of the malleus. It's also attached directly to the tympanic membrane. And then we have the pars flaccida, which lacks the central layer of fibrous tissue. The cone of light, which you can see labeled here, is going to be what allows that reflection whenever we use an otoscope when we're checking the ear. Next, we're going to look at the middle ear. Gray's 906 and 912 are going to give us more information on it. The middle ear, you can see we have the 3 ossicles within the tympanic cavity. They extend between the tympanic membrane, which we just talked about, and the vestibule of the inner ear, which would be on this side. The tympanic cavity lies mainly within the petrous part of the temporal bone. So again, you're going to have your malleus, your incus, your stapes here. You can see there are ligaments that stabilize these auditory ossicles, which assist with the movement. There's several clinical correlates that are associated with the middle ear. You have them listed in your notes. Ossicles, of course, these are going to be the first bones to ossify in a fetus, and they should be mature by birth. We have a laryngotomy, which is going to be when they place tubes in the ear. You have otitis externa and otitis media. These are different. Itis, of course, means inflammation, so these are different clinical correlates that are involved with the external ear or the middle ear. Other types of infections that are discussed here as well, make sure that you review those and are familiar with them as well. If we go to the sagittal section of the middle ear, what you can see here is these mastoid air cells. Of course, ear infections in the middle ear can normally happen and really intensify because of these mastoid air cells. They don't have good circulation, they don't have good perfusion, and so when infection occurs in this area, it's hard really to get it out because there's not a good defense mechanism. From the mastoid air cells, an infection can go to the sigmoid sinus, into the jugular vein, and then this infection can get into the circulatory system of the body. And, of course, that could lead to some negative outcomes if it's not controlled. We have the mastoid antrum, which is a section of the middle ear. Of course, this is where our semicircular canals often lay. We talked about that facial nerve. Note here, there's a canal for the facial nerve, and then it's going to exit through the stylomastoid foramen, and it goes through and actually comes down here. So the facial nerve itself does not pass through the middle ear, but know that it is in close proximity to it. You have the tensor tympani, which is shown here. This is the ligament that's going to attach to the malleus to assist in movement of that ossicle. You can also see the carotid artery is actually in close proximity to the middle ear as well, and the jugular foramen, which is not shown in this picture, is also. Where this is pointing to, this is where the tympanic nerve, which is part of cranial nerve 9, is actually going to sit here and come out of this area. So we have several nerves, several arteries that are in close proximity to the middle ear. So often when we have any type of surgical intervention in this area, there's several aspects that we could assist in monitoring. So you need to make sure you familiarize yourself with the anatomy and know what monitoring could be applicable to this part of the ear. So now we're going to fast forward to the inner ear. And the inner ear has the cochlea and the semicircle canals, and these of course are within the temporal bone. So if you imagine the skull, here's the temporal bone. If we zoom in, you can see your cochlea here and the semicircle canals. Of course, this is going to be your middle ear, your external ear going outward, and then going inward you can see the vestibular nerve and the cochlear nerve, and they come together, of course, to form the vestibular cochlear nerve, which is our cranial nerve 8, which is exclusively sensory. So as we said, the inner ear has a bony labyrinth and a membranous labyrinth, and we're going to look at both of these here in a second. If you go to page 5 of your notes, you essentially have a bunch of words, and these are going to be all talking about the inner ear. So make sure that you apply these with the pictures on page 4 and page 6. So the bony labyrinth is going to be the bony cavity. It's filled with perilymph, which is primarily sodium, and it's lined with periosteum. So whenever you look at this picture right here, this area, the outside area that's this light blue, that's going to be your bony labyrinth. So again, this is our middle ear. Now we've gone to the internal ear. This is going to be that cochlea with those semicircle canals. Okay, so your bony labyrinth is going to be this light blue outer section here. Okay, it's going to consist of your vestibule, your semicircle canals, and your cochlea. So all of these include bony labyrinth. You also have your membranous labyrinth, and this is going to be where the perilymph is suspended in the bony labyrinth. It's actually filled with endolymph, which is primarily potassium. So that's the difference between the two. Perilymph is sodium, endolymph potassium. It's going to consist of those semicircular ducts, the cochlear duct, the utricle, and the saccule. And so again, in this picture, the light green here in the middle, that's going to be your membranous labyrinth. So that's the difference between the two. Bony's on the outside, membrane on the inside. When we talk about the cochlea itself, the cochlea has 3 fluid-filled chambers. Okay, it has the scala vestibule, the scala media, which is the cochlear duct, and the scala tympani. So when we look at the cochlea, these aren't labeled in this picture, but I'm going to point them out to you. The scala vestibule is actually going to be this area here. Okay, the scala media is going to be this center area here. And the scala vestibule is going to be this area here. So each of these is divided. This picture in its entirety is showing you the cochlea. The vestibular membrane is going to separate the scala vestibule from the scala media, and that's going to be this darker green here. It separates these two. The basilar membrane is going to separate the scala media from the scala tympani, and that is going to be the membrane on this side. So this dark green membrane here. Okay? The other 2 areas of the inner ear, we have the organ of Corti and we have the spiral ligaments. So the organ of Corti is within the tectoral membrane. It's where the hair cells are. So it's actually going to be this little strip that we have here. You can see it labeled, and the, I guess, brown or goldish color is representative of those hair cells, and we're going to talk about those. The movement of the hair cells is what actually causes a change in membrane potential. So that depolarization, the hyperpolarization, for us to get a waveform from our auditory evoked potentials, it exclusively is going to be dependent on these hair cells here in the organ of Corti. Of course, this is going to extend from the base to the apex of the cochlea. So we have the base here all the way to the apex, which is within, so you can see it extends the entire length. And last but not least, we have the spiral ligament, which is part of the inner ear, and this is going to be a thickened periosteal lining of the bony cochlea. It forms the outer wall of the cochlea duct, and so that is going to be the spiral ligament. So again, take the words that you have on page 5, make sure you've labeled the picture on page 6, you understand where everything is and how it is related to one another. Now the vibrations of the ossicles, which are in the middle ear here, apply to the oval window, which you can see is this orange aspect here. It's going to spread through the cochlea and induce vibrations of the basilar membrane. So you can see the arrows, the vibrations are spreading through the cochlea, and they're going to induce vibrations on the basilar membrane, which is this dark green section here. That's the membrane. The movement is transduced into afferent nerve excitation by the hair cells. So the vibrations are going to go through the basilar membrane and begin to affect these hair cells within here. And the pressure is going to dissipate out the round window, which is here. So imagine it goes in, the vibrations go throughout the cochlea. It's going to affect this dark green basilar membrane, which is therefore going to affect the movement of the hair cells, and then it's going to dissipate and go out the round window. The other portion of the inner ear is involved in vestibular function. So we just talked about our auditory function. We also have a vestibular function, which is our balance, right? Our equilibrium. So the utricle and the saccule contain receptors which are going to respond to linear acceleration, and the receptors in the semicircular canal are going to respond to angular acceleration. So there's two components. Of course, we have our vestibular nerve and our cochlear nerve, which cochlear is our auditory, vestibular is our equilibrium, our balance, and then they come together and they form the vestibular cochlear nerve. So we have two different functions here and two different nerves that eventually come together to form cranial nerve 8. So when we talk about the labyrinths, right, we said we had a bony labyrinth and a membranous labyrinth. And we just talked about the auditory function, so now we're going to talk about the vestibular function and how these play a different role. So we already looked inside of the cochlea, and then here are our semicircular canals. So the osseous or the bony labyrinth is going to be our semicircular canals. You can see here's the anterior, the posterior, and the lateral. And notice that they're kind of a lighter teal color. So these are going to represent the bony labyrinth or the osseous labyrinth, and these detect rotational acceleration. That's different than our membranous labyrinth, which is going to be our utricle, which detects horizontal acceleration, and our saccule, which is going to detect vertical acceleration. And you can see here's our utricle, here's our saccule, and these are representative of a more deep teal color, and that is showing that they are actually membranous and not osseous. So when we look at the vestibular function of these labyrinths, ultimately, what is happening is we said there's vibrations of the basilar membrane, right? And the organ of Corti. We talked about those a few slides ago. So this is going to bend these hair cells. So if we look at this picture here, we're zooming in, okay? and we're looking at the hair cells within these labyrinth. So this is what it looks like. You can see we have the cilia of the hair cell itself, and then these are actually attached to the vestibular nerve. Okay, so they're called stereocilia. When we bend the stereocilia, it causes a change in ionic conduction at the surface of the cell, which we could see we're bending. We have ionic conduction occur, and then a current flow and a voltage change happens, sending stimulation through that vestibular nerve. Okay? The neurotransmitters that are often involved here are going to be glutamate and aspartate, and those are both excitatory neurotransmitters. So if we zoom in at the stereocilia specifically, if you look in the middle, this is whenever we are at resting. So just think of your typical action potential. Let's say resting membrane potential is 90 milliamps, right? So the hair cell is upward, it is happy, it is at resting. This dark black part of the hair cell is called the kinocilium, and that's kind of our leader. Depending on which director the kinocilium goes will determine if we're depolarizing or hyperpolarizing. The rest of the hair cells are called the stereocilia. So whenever we lean towards that kinocilium, that is going to depolarize. So we're releasing the glutamate, the aspartate into the vestibular nerve, and we are increasing to a more positive membrane potential. So you can see now we've gone from 90 to 160 spikes per second. This is depolarization. This is excitation. Okay? Conversely, if the hair cells move away from the kinocilium, away from the stereocilia, this causes hyperpolarization or inhibition. So now you can see we've gone from 90 spikes per second to 20 spikes per second. And conversely, you do not see a release of neurotransmitters here. So this is how the vestibular nerve is excited, or we have hyperpolarization. Now, when we look at the auditory function, so this should actually say auditory function at the top, we're looking at that basilar membrane, okay? So the base of the basilar membrane is thin and stiff, and that's for faster frequencies, so this is our base here. And the apex of the basilar membrane is wide and more flexible, and that's for lower frequencies, which we can see this is the apex here. So whenever we look at this, this is our cochlea. It is, wound up, but if we straighten it out, that's what we're showing here. And so we're always going to have our base on the left-hand column. You can see that it is more stiff, and then the apex, which is going to be more flexible for those lower frequencies. As frequencies come in, if they go to the base, which is going to be our higher frequencies, the base of the basilar membrane will respond. Now, medium frequencies is going to be kind of in the middle of the basilar membrane, and lower frequencies are going to be at the apex of the membrane. Most of human hearing is between 50 and 16,000 hertz, and then human speech is actually 100 to 8,000 hertz. So those are going to be on the lower frequency end, more in the middle to the apex of the basilar membrane. The perception of frequency is based on two things: the location of the basilar membrane and the type of hair cells stimulated. So as you can see, the location of the basilar membrane is very important because different areas can translate different frequencies. And of course, those hair cells, you can see here in the cochlear duct in the center, those are going to be the different hair cells that are stimulated, which are going to give us different perceptions of frequencies. So there are different types of hearing loss. You have nerve deafness, and this is normally when those hair cells cannot conduct the impulses, therefore we don't have that ion exchange, we don't have the neurotransmitter exchange. But then you also have conductive deafness, and essentially think about conduction of an impulse. So the conduction of the impulse is blocked in some way for some reason, and so the sound does not even make it to the hair cells. Okay? So for the board exam, you need to know the different types of hearing loss and how those affect your auditory evoked potentials. So nerve deafness, conduction deafness, those are two different types of hearing loss that you definitely want to make sure that you feel comfortable with. Whenever we look at how the ear correlates to intraoperative monitoring, as we all know, it's cranial nerve 8, our vestibular cochlear nerve. It's exclusively sensory. And so the way that we monitor this is through our auditory brainstem responses. You do need to know the pathway for the auditory brain responses, so I'm going to go through it quickly. There is one caveat to this picture. I'll talk about it here in a second. So we know that we have 5 waveforms when we do intraoperative auditory evoked potentials. You actually have 7 waveforms when you do clinical auditory evoked potentials, and you need to know the generator of each of these. So wave 1 actually comes from the external portion of the nerve itself. Okay, so a common way to remember these generators is E. coli. E-C-O-L-I. Okay, so E is wave 1. That's the extracranial part of the auditory nerve. Now, when we go to C, C is going to be wave 2. That is going to be our cochlear nucleus. Wave 3, O, is going to be the superior olivary complex. Superior olivary complex. And this is actually where this picture is incorrect. From the cochlear nucleus, it goes to the contralateral superior olivary complex. So wave 3 is actually generated from the contralateral superior olivary complex in the pontine medullary junction. Wave 4 is going to ascend from the medulla pons towards the membrane in the lateral lemniscus. That is our L of E. coli, the lateral lemniscus. And then wave 5 is going to be generated in the midbrain at the inferior colliculus. That is our I, inferior colliculus, in the midbrain. Okay, those are our 5 waveforms. For intraoperative. For clinical, you have 2 more. Wave 6 is going to be from the medial geniculate body that's in the midbrain, and then wave 7 is going to come from those auditory radiations, which goes to Heschel's gyrus in the auditory cortex. So one more time, if you remember E. coli for your generators of your auditory evoked potentials, wave 1, E, the extracranial portion of the auditory nerve. Wave 2, C, the cochlear nucleus. Wave 3 is the contralateral superior olivary complex in the pons, medullary junction. Wave 4, L, the lateral lemniscus, going from the pons towards the midbrain. Wave 5, the inferior colliculus of the midbrain. Wave 6 is the medial geniculate body in the midbrain, and wave 7 is the auditory radiations going to Heschel's gyrus in the auditory cortex. Ultimately, when you're doing auditory evoked potentials, you want to see waves 1, 3, and 5 are your primary concerns. You are really interested in the amplitude of 5, but you're actually interested in the latency of 1, 3, and 5. We say the absolute latency. That means just the latency of those individual waves. And then you're also interested in the inner peak latency from waves 1 to 3, 3 to 5, and 1 to 5. And this is going to be on the ipsilateral side. So when you think about this, you need to know the anatomy pathway to know what you are thinking about. So I like to teach, students when I'm teaching them auditory evoked potentials. Imagine you have a chair for wave 1, a chair for wave 3, and a chair for wave 5, okay? Wave 1 is the extracranial part of the nerve. Wave 3 is at the pontine medullary junction in the superior olivary complex. And wave 5 is in the midbrain at the inferior colliculus. And just think about that pathway. If you have a deficit, where does it fall between those chairs? Is it before the nerve? Is it between chair 1 and chair 2, which is representing, wave 3? Is it between the nerve and the pontine junction? Or is it between wave 3 and wave 5, which is going to be between the pons and the midbrain? And then that's going to tell you how everything shifts based off of that. And so that's something for you to remember. If you have questions about this, feel free to email me and I can answer more. But just wanted to quickly relate the anatomy to the waveforms. Also for the contralateral ear, again, if you think about these generators, you should see a wave 3, you should see a wave 4, and you should see a wave 5, because the sound is going to travel from that ipsilateral ear and then go into the brainstem and stimulate the brainstem generators bilaterally. But you should not see a wave 1, because if you're stimulating the left ear, right, the right extracranial part of the auditory nerve is not getting any stimulation. And that is why we don't see a wave 1 from the contralateral ear, but we should see a wave 3, 4, 5. Okay? So that is the ear and how it's related to IONM. Now there are more clinical correlates. You have a page in your handout section that have clinical correlates for the eye, the ear. So make sure that you look over those, look up those clinical correlates, and let me know if you have any questions on those. So as always, if you need to take a break, this is a great time to take a break before we get into the eye and the orbit. All right, so moving along to the eye and the orbit. When we look at the eye, there are some basic aspects of the anatomy that we do need to know. This is the medial side. This is the lateral side of the eye. We can see on the lateral side, we have what's called the lateral canthus. The canthus is just kind of that corner of the eye. You have a lateral canthus and a medial canthus. Of course, we have an upper eyelid and a lower eyelid. The pupil is the black part of our eye. The iris is the color portion of our eye. The sclera is the white part of the eye. And then, of course, we have our lacrimal gland, which is kind of on that lateral aspect superior to the eye. The medial canthus on each side, it's not labeled here, but you have what's called a lacrimal punctum, and this is where tears come from whenever the eye needs to be lubricated. When you think about the orientation of the eyeball itself, it is actually not in a perfect orientation. So let's look at this. The medial orbit walls are nearly parallel, but the lateral wall is nearly perpendicular to one another. So the orbital axis is actually 23 degrees from midline. So if you imagine, here's midline here, and then we draw this line here, we're about 23 degrees from midline. So that is the baseline for the orbit, and that's something that we need to be aware of, especially when we are testing the extraocular muscles. More information on this, Gray's 883 and 1068, as well as Netter's 82. Another aspect that's important to know is the actual orbit itself. And whenever you look at the orbit, it is composed of 7 bones. We've already talked about these in our last section, but we have the zygomatic bone, which is here in blue, the maxilla, which is here in purple, the nasal bone, which is going to be this darker purple, the lacrimal bone, which we can see here in green, the ethmoid bone, the frontal bone, and the sphenoid, which is here in pink. Okay, so all of these bones make up the orbit itself. It's also important for us to know a few of the foramen that are within the orbit, because we have several important structures that pass through these. So the optic canal is going to transmit the optic nerve and the ophthalmic artery. So the optic canal is located right here. The superior orbital fissure, which is going to be this larger hole here. The superior orbital fissure conveys other nerves and vessels which supply the orbital content and the face. Some of the nerves and vessels emerge onto the forehead after passing through the supraorbital notch. So they may come out of here, go upward, and then exit through the supraorbital notch to go onto the forehead there. We also have the inferior orbital fissure, which you can see is this little hole right here. And this is continuous with the pterygopalatine fossa posteriorly and the infratemporal fossa inferiorly. An important nerve, the maxillary division of the trigeminal nerve, runs in the floor of the inferior orbital fissure, and it passes into the infraorbital sulcus and emerges onto the face at the infraorbital foramen. So imagine the nerve comes from this inferior orbital fissure. It goes down in the orbit and actually comes here through the infraorbital foramen onto the face. And remember that maxillary division is providing sensory innervation of the face. So anytime you're doing a surgery that involves the orbit or monitoring it in some way, know that all these structures and important vessels and nerves are passing in these areas to understand kind of where you are surgically and what's at risk. I just wanted to quickly just point out that the orbit is very close to the paranasal sinuses, and this is very important as well. When we look laterally, you have your frontal bone here, you have your zygomatic bone here that protects the orbit, but medially you can see the paranasal sinuses are separated only by a thin layer of bone there. So this can be significant if there's any type of sinus infection. It can lead to the orbit, so that is something that we would want to keep in mind if there were some type of infection in there when we're doing monitoring. Know that there is a higher risk for those structures to be affected and could affect our baseline waveforms. So for a great picture, you can look at Gray's 1017 and Netter's 82. Now when we really get into the eye, there's several structures that we need to be aware of. Gray's 880 and 886, as well as Netter's 83, are great pictures of these and have some more details if you need to look into that. The first thing we're going to talk about here is the orbicularis oculi, and this is one of the major muscles that we commonly monitor for cranial nerve 7. You can see it here in this sagittal cross section. It lies within the eyelid. It's very close to the eye. As I said, it's innervated by cranial nerve 7, so we often will monitor this. When I place needles for my orbicularis oculi, I normally pinch the eyebrow and then place the needles going medial to lateral so that they lay on the eye. You can see this isn't a deep muscle, and if you went straight in, you would hit the frontal bone, so it's more of a shallow angle when placing those. The tarsal plates serve as protection. Within them, they do have glands that are going to secrete oily substances. This is going to lubricate the lid and prevent tears from overflowing on the face. So the tarsal plates are actually these kind of pinkish purple bones here, and as we just stated, they do lube the eyelid, and they also, of course, you can imagine if the tears build up here, they kind of prevent them from just falling over as well. The conjunctiva is very important. This is a thin, translucent mucous membrane that lies in the inner surface of the eye. It essentially is going to cover the entire anterior surface of the eye. You have a palpebral conjunctiva and an ocular conjunctiva. So you can see it circled here. This is the conjunctive fornix. You have your palpebral and your ocular. They're labeled here. They're saying the ocular is the bulbar, which is going to be over here. The palpebral will be here. The palpebral conjunctiva is firmly attached to the tarsal plates, and it is highly vascular. That is very important. You can see it's right here on the tarsal plate, and it is highly vascular. That is different than the ocular conjunctiva, which we just said lies here on the orbit. It's loosely attached to the sclera, which is the white part of our eye, and because it's translucent and avascular, that's why we can see the white of the sclera. Over the cornea, the ocular conjunctiva consists of a thin layer of epithelium. So, similar structures, but have very different things. So make sure you note those. We also have the orbital septum. This is a thin membrane that arises from the orbital periosteum along the entire rim of the orbit. It passes into the eyelid and emerges with the tarsal plates. So ultimately, that's going to be, throughout the structure to the tarsal plates. Lastly, we have the bulbar fascia. This is the thin fibrous capsule that covers the external surface of the eye. It's going to go, and here it is here, from the optic nerve all the way to the cornea sclera anteriorly. It is analogous to a ball and socket joint. So the bulbar fascia is pierced by the tendons of the extraocular muscles and is reflected backward around each muscle to provide sheath. So it's kind of like a protective layer if we think of it in that way. Now when we look at the eye from a different angle, let's say we're looking at it from an axial transection, we can see the lens here. And the lens is biconvex, okay? It's approximately 1 centimeter in diameter. It's enclosed in a capsule and is attached to the ciliary bodies by the suspensory ligament. So you can see here's the suspensory ligament, and it attaches to the ciliary bodies, which are lateral here. Contraction of the muscles. This happens through the parasympathetic system. This is going to result in relaxation of the suspensory ligaments. and the lens is going to round up and become more convex. So these muscles contract, the ligament releases, the lens rounds up, and this is what allows us to have near vision. The process of altering the convexity of the lens is what really brings an object into focus on the retina and is known as accommodation. So another aspect that is important in this pathway is we have something called the aqueous humor, and that's going to be secreted by the ciliary processes, and it's going to circulate through the eye. So it actually goes from the anterior chamber into the posterior chamber. And when this system is blocked, that's when we get glaucoma. And if the glaucoma is not corrected, pressure in the eye can actually squeeze the retina, causing capillary death, and this could lead to blindness. So the circulation of that aqueous humor is very important in the functioning of the eye. Of course, we have some other clinical correlates that are mentioned here. We have presbyopia. This is when the lens cannot ball up, as we just discussed, and normally this happens and it can be easily fixed by getting a pair of reading glasses. Cornea transplants, those are normally successful because the cornea is avascular, and so a lot of times it's not a high-risk procedure due to that avascularity. Cataracts are caused when the lens is cloudy, and so the vision is skewed there. And then we have astigmatism, which is caused from the abnormal curvature of the eye or the cornea itself. So those are some interesting points of the eye. Again, for more information, you can reference the pages on the top of your notes. Now we're going to get into the extraocular muscles. And whenever we look at this picture, we have a lateral view as well as an anterior view of the eye. The extraocular muscles are controlled by 3 cranial nerves of the eye: cranial nerve 3, which is the ocular motor nerve; cranial nerve 4, which is the trochlear nerve; and cranial nerve 6, which is the abducens nerve. I like to start with the abducens nerve because it is going to innervate the lateral rectus muscle, which we can see here as well as here. The trochlear nerve, cranial nerve 4, is going to innervate the superior oblique muscle, which you can see in this picture here, as well as you can see the pulley here as well. And then when we go to cranial nerve 3, which is the ocular motor nerve, it is going to innervate all the other muscles, which include the levator palpebrae superioris, which you do not see in this picture, but we'll see it in the next. It also is going to innervate all of our recti muscles. So we have the superior recti, the medial recti, and the inferior recti. And it also innervates the inferior oblique muscle. So you do need to know these cranial nerves and what muscles they innervate for your board exam. So a lot of times I just remember that the abducens nerve innervates the lateral rectus, the trochlear nerve innervates the superior oblique, and cranial nerve 3, the ocular motor nerve, innervates everything else. This is another picture that's going to actually show us the cranial nerves and their attachments to those muscles. It's also important to know where the cranial nerves are originated in the brainstem, and we're going to look at that in more detail, but just to quickly go over it, first you have cranial nerve 4, which is your trochlear nerve. One thing that is unique about cranial nerve 4 is that it is the only cranial nerve that comes from the dorsal aspect of the brainstem. So you can see here this cranial nerve comes from the back of the brainstem, wraps around, and comes and innervates the superior oblique muscle. Cranial nerve 6, the abducens nerve, is going to come from the pontine medullary junction, and it's going to innervate the lateral rectus. And then, of course, we have cranial nerve 3 that comes, and it splits into a superior branch and an inferior branch. The inferior branch is going to go to that inferior oblique, as well as the ciliary bodies, which we just discussed is involved with the parasympathetic aspect of contracting the lens, and we'll talk about that more here shortly. The superior aspect is going to go up and innervate the levator palpebrae, which you can see here, the superior rectus. And so those are the pathways of the cranial nerves from the brainstem to those extraocular muscles. Now, it's also important for us to note the function of these muscles, because if we're going to be monitoring any of these cranial nerves when we see our patient preoperatively, we would do our normal neurological evaluation for the muscles that are at risk. So when we're doing clinical testing, each muscle is tested in its position from baseline. And remember, that baseline is that 23-degree aspect from midline. So we'll ask the patient to look outward, parallel with the axis of orbit, and with the eye and the muscles aligned, we'll ask the patient to do the appropriate movement. So in this picture, you have the vertical axis. So this is movement that if we focused at midline, the eye going medial or the eye going lateral. So in this top picture, this is showing you the different muscle groups that contribute to the eye adducting, meaning going towards the midline, versus here, this is showing us the muscles that allow the eye to go lateral or abduct. This second row is showing us from the horizontal axis. So imagine you have a line going through that axial or horizontal axis of the body, and you're going to have muscles that allow the eye to go up or elevate and go down or depress. And then lastly, your rotator. So now we're really thinking about a 3D axis. So imagine you have a ball in your hand and you're rotating it to the left or rotating it to the right. And that's what this last line is showing you. So we have our rotator muscles. We have specifically medial rotators and lateral rotators. So when we want to test these individual muscles, if you look in your notes, the way that I like to think about this is that our rectus muscles, you're actually going to get the eye to go in the direction of what that muscle is named. So for instance, the superior rectus muscle, superior, you're going to ask the patient to look up. The inferior rectus muscle, inferior, you're going to ask the patient to look down. The medial rectus, you're going to ask the patient to look medially or towards the midline. The lateral rectus, you're going to ask the patient to look laterally. So those are fairly easy to remember. Now your oblique muscles, it's a little confusing. With those, you're actually going to do the opposite of what you would think. So for the superior oblique muscle, you may think that you would ask the patient to look up. But in actuality, that is incorrect. So for the superior oblique muscle, you are going to ask the patient to look downward. And with the inferior oblique muscle, you're going to ask the patient to look upward. So those are the opposite of what you would think. Now in actuality, as you can see from the picture I have here on the screen, most of these muscles do not work individually. It takes multiple muscles to get a specific movement of the eye. So just keep that in mind, especially when you're testing a patient. If you ask them to look outward or adduct the eye, know that you're actually getting influence from the medial rectus, the superior rectus, and the inferior rectus all at the same time. So now we're going to look at the specific nerves that are involved with these extraocular muscles. First is going to be cranial nerve 4, or our trochlear nerve. As you can see, cranial nerve 4 is the only cranial nerve that emerges from the brain dorsally. This is extremely important whenever you're doing craniotomies or you're monitoring procedures where the brainstem is at risk. If you're doing a posterior entry point, know that cranial nerve 4 is the only cranial nerve that exits from the posterior brainstem. That's very important to note. It emerges medially near the midbrain pontine junction. It's going to pass laterally around the cerebral peduncles, and it's going to continue anteriorly through the lateral wall of the cavernous sinus and enter the orbit through the superior orbital fissure, which you can see here. Cranial nerve 4, as we've already said, supplies motor fibers to the superior oblique muscle. If we have a lesion of cranial nerve 4 at the root of the nerve, this of course will lead to the superior oblique muscle being paralyzed on the ipsilateral side. If we had any type of cortical damage to the brain, such as stroke or trauma that involved the frontal eye field, this would also affect the function of cranial nerve 4 on the ipsilateral side. Next, we have cranial nerve 6, which is the abducens nerve. The abducens nerve, as we've already said, is going to supply motor innervation to the lateral rectus muscle of the eye, and this allows the eye to abduct or go outward or laterally. Cranial nerve 6 is going to emerge between the pontine medullary junction, and it is going to course anteriorly and pierce the dura. It's going to go through the cavernous sinus as well as the superior orbital fissure, which we can see here. If we have injury to cranial nerve 6 in the pons or outside of the brain, this is going to result in paralysis of the ipsilateral lateral rectus muscle. So the affected eye is slightly introverted and it does not abduct on attempt to look laterally. The opposite eye will be able to function normally because it is intact. Cranial nerve 6 can also be affected if we have a fourth ventricle tumor. This is something we commonly see in the pediatric population. The lesion of the abducens nucleus in the fourth ventricle is going to damage the motor neurons, and this will also result in paralysis of that lateral rectus muscle on the ipsilateral side. So we're going to look at the brain next week, but know that the fourth ventricle is really dorsal to the pons. So if you had a tumor here, of course it could affect the nucleus of the abducens nerve. Lastly, we have the ocular motor nerve, which is cranial nerve 3. The ocular motor nerve is going to supply motor innervation to 5 of the 7 extraocular muscles. This is going to include the levator palpebrae superioris, the superior rectus, the medial rectus here, the inferior rectus, and the inferior oblique. It also supplies parasympathetic innervation to the constrictors of the pupil and the ciliary muscles. Okay? When we look at the parasympathetic aspect of the ocular motor nerve, it has preganglionic fibers that are going to originate in the nucleus, in the brainstem, and travel with cranial nerve 3. When it enters the orbit, they are going to communicate with the ciliary ganglion where they synapse. So you can see, here's the ciliary ganglion. So that inferior branch is going to go to the ciliary ganglion. And then the postganglionic parasympathetic fibers are going to travel by the short ciliary nerve, and these are what will contract the sphincter pupillae and the ciliary musculature. This is what allows accommodation, disconjugate movement, and pupil constriction for the eye. When we think about the sympathetic aspect of cranial nerve 3, this is actually going to originate in the thoracic column of the spinal cord, and it's able to get to the orbit by traveling on the superior cervical ganglia. So the postganglionic fibers are going to go to the head by the carotid nerves. These fibers are going to branch at the ophthalmic artery, and they're going to travel on the long ciliary nerves to enter the eye and innervate the dilator pupillae. So our sympathetic aspect of cranial nerve 3 actually dilates the pupil, and our parasympathetic aspect of cranial nerve 3 is going to constrict the pupil. There are several clinical correlates that are listed in your notes. I'll let you read over those. And again, as always, if you have any questions, be sure to send me an email. Now, the cavernous sinus is an important aspect of the cranial nerves for extraocular muscles. When you look at this sagittal section of the cavernous sinus, what you'll notice is that cranial nerve 6 passes through here, 2 portions of cranial nerve 5, cranial nerve 3, and cranial nerve 4. Okay? You also have the internal carotid artery within the cavernous sinus as well. So if something happens to the cavernous sinus, we have what is called cavernous sinus syndrome. I want you to look this up, but just knowing the basic functions of these cranial nerves, you can imagine that if something happened to the left portion of the cavernous sinus, you would have loss of all extraocular muscles to the left eye, as well as sensory deficits to the left face through the maxillary and the ophthalmic division of the trigeminal nerve. Another clinical correlate is Horner syndrome. And we talked about the parasympathetic and the sympathetic aspects of cranial nerve 3. So essentially what Horner syndrome is it's a deficit in the sympathetic innervation of the eye. So there's several signs and symptoms that we will see that correlate with Horner syndrome. Some of those are miosis. That's whenever you have loss of constriction of the pupil. And this is because of the unopposed action to the parasympathetic innervation. So you'll see here pupil constriction. Okay. You'll also see ptosis of the eyelid. So you'll have some drooping of the eyelid, and that's because of paralysis of the superior tarsal muscles. You'll have flushing of the face, and that is from the loss of the sympathetics. So you lose that vascular tone in your face. You'll also have what's called anhidrosis, which is absence or diminishing of sweating. And all of these things together are known as Horner syndrome. So look over this picture. It shows you the different deficits that are associated. Here it's correlating the parasympathetics from the thoracic area of the cord that are going through that superior cervical ganglia into the orbit, and then it lists all the deficits that are associated as well. Next, I want to talk about the vasculature of the eye, and the primary artery that is involved with the eye is the ophthalmic artery. The ophthalmic artery is going to enter through the optic foramen, and it's going to follow the nasociliary nerve, which is a branch of the trigeminal nerve. It has several branches that supply various portions of the eye. So you can see here's the internal carotid artery, and off of that branches the ophthalmic artery. Now this is going to be our optic nerve. So the ophthalmic artery kind of goes around the optic nerve, and then one of the first branches that we see is the lacrimal artery here, and the lacrimal artery supplies the lacrimal gland. Next, we actually can see the long and short ciliary artery. So here's the short, and the long is actually over here. It's not labeled. These are going to supply the ciliary body and the iris, as well as the retina. Over here you have your anterior and your posterior ethmoid arteries. These are going to supply the superior aspect of the inner nose. So a lot of times when people have a nosebleed, it's from these arteries. You have the supraorbital artery, which you can see here, supplying the superior aspect of the orbit. You have the supratrochlear artery, and this one's very important because it's actually the end branch of the ophthalmic artery, so there is no anastomosis. If this artery is compromised, you'll definitely have a deficit there. And then you have the dorsal nasal artery here, which is going to anastomose with the facial artery, so it does have an alternate aspect of circulation. You can also see within the optic artery that you have the central artery of the retina. This goes within the optic nerve, and we're going to look at that next. So this is showing you the ophthalmic artery. This is the central artery of the retina that's going to go within the optic nerve and travel within that nerve. So this is going to pierce the dura, run with the optic nerve. After it passes through the cribriform plate of the sclera, that's going to be this aspect here. It passes through there. It's going to divide into 4 major branches, and we can see some of those branches here. It's going to supply the inner neural part of the retina. And this is also an end artery, so there's no anastomosis with other vessels. Therefore, if it is compromised, this will result in blindness because there is no additional blood supply to this area of the eye. So if you look at page 17 and 18 in your notes, this is actually going to be 2 different charts that you need to know: the extrinsic muscles of the eye and the intrinsic muscles of the eye. So you need to know both of those. If you fast forward to page 19 of your notes, this is going to show you the visual pathway and the correlated deficit. So whenever we look at the visual pathway, you have to think of a way to get this straight in your mind because it can be very confusing, but once you get it and you feel comfortable with it, stick with however you have chose to remember it. So I'm going to quickly go through it. Ultimately, whenever you look at the orbit, the medial aspect of the eye sees the lateral visual field. Okay, so the medial aspect of the eye sees the lateral visual field, which you can see for the left eye. This is showing it in red. The medial aspect of the right eye is showing it in blue. Okay, the lateral aspect of the eye sees the medial visual field. So here, the lateral aspect of the eye in blue sees the medial visual field. On this side, the lateral aspect of the eye in red sees the medial visual field. Okay? Once you've got that, now we have to talk about the pathway. So let's start with the medial aspect of the eye. We already said the medial eye sees the lateral visual field. From there, it is going to run down the medial aspect of the optic nerve. Once it gets to the optic chiasm, it is going to go to the contralateral optic tract and the contralateral visual cortex. So one more time, the medial aspect of the eye sees the lateral visual field. It runs on the ipsilateral optic nerve, it crosses over at the optic chiasm, and goes to the contralateral optic tract and optic cortex. Conversely, the lateral aspect of the eye that sees the medial visual field is going to run down the ipsilateral optic nerve, and then it is going to remain on the ipsilateral optic tract and ipsilateral visual cortex. So when you look at this as a whole, once you get past the optic chiasm and you're at the optic tract, you are seeing the lateral aspect of the ipsilateral eye and the medial aspect of the contralateral eye. This is the same for the visual cortex. At the visual cortex, you are seeing the ipsilateral, lateral eye, and the contralateral, medial eye. Okay? If you can get that straight in your mind, you can conclude any of these deficits. So let's talk through some of these deficits. First in this picture, we see, First in this picture, we see number 1. Number 1 would be if the entire left optic nerve is cut. So if we cut the optic nerve, what happens? We lose sight in the left eye. That's what the gray is representative of. We've lost all sight in the left eye. Everything in the right eye is perfectly normal. So this is just ipsilateral loss of vision. If we go to number 2, in number 2, we are seeing partial damage to the left optic nerve. So here, the information is going to be dependent on, did we lose the lateral aspect or the medial aspect of the nerve? And in this situation, they're saying the lateral aspect of the nerve, which is going to lose part of the vision to the ipsilateral eye. And they call this the temporal part of the vision. So your lateral, the lateral aspect of your orbit is called the temporal part. So for number 2, we would say the temporal part of the left retina is lost. And remember, the temporal part is seeing the medial field, so you lose the medial field of that eye. Now, if we cut at the optic chiasm, the optic chiasm is where both pathways cross. So if we cut at the optic chiasm, the temporal, which is the lateral portion of the visual field, would be lost. The crossing fibers are cut in this example. So you can see we have now lost the temporal part of both visual systems, and this is actually called homonymous bitemporal hemianopsia. It's a mouthful, I know. Homonymous, meaning the same, bitemporal, meaning both lateral aspects of the eye, hemianopsia, meaning half of the vision field is lost. Okay, next, number 4, now, and number 5, so now we've transected the optic tract or the lateral geniculate nucleus. Both of these, we will result in vision loss, and it's going to be vision loss specifically to the right visual field. When we look at this can be called a couple of different things. So specifically, the optic tract, this is called homonymous hemianopsia. So that means just one side, we're losing the vision there. When we're at the geniculate body, this is going to be the same thing, homonymous hemianopsia. So whether we have cut 4 or 5, it's going to result in the same deficit, homonymous meaning same side, hemianopsia meaning half of the vision field is lost. And you can see that here in both 4 and 5. I wanted to also look at this picture as well. So this picture we've already discussed 1 and 2 and 3 and 6. But I did want to also add if something actually happens at the cortex itself. Okay, so whenever something happens at the cortex, we will have what's called quadrant anopsia, and that means you're actually just losing one quadrant of the visual field. So that's different from the others that we've spoke about. So definitely look this up. There's several things out there online for more information on this. At first it can be very confusing, but I think once you get it straight in terms of the pathway and then you think about each transection, how would that affect the visual field? I think the hardest thing is to correlate it with the names. So make sure that you get those names straight in your mind and what aspect of the track it's associated with. So the last thing that we're going to talk about today is how the eye is associated with intraoperative monitoring. And as we know, whenever we're looking at cranial nerves 3, 4, or 6, we will just monitor EMG to look at the motor aspect of those nerves. But we also have cranial nerve 2, the optic nerve, and this can be assessed by visual evoked potentials. Visual evoked potentials can be done clinically or intraoperatively. They can be done by looking at a checkerboard clinically, or you have goggles intraoperatively. Most people are not doing visual evoked potentials intraoperatively anymore. They are the most affected by anesthesia, and they're very hard to obtain. So you will see these more clinically than intraoperatively. I personally have never done visual evoked potentials intraoperatively in my career, and most of the people that I've talked to have not either. But it's still on the test, so we do need to know about it. The waveform that is associated with visuals is P100. Technically, we're looking at the brain activity of the visual cortex, which is in the occipital lobe. That's why those are going to be our recording electrodes there. We're looking how it travels from the retina to the visual cortex, so the whole pathway that we just looked at previously. It's going to result in this waveform, which is P100, and it's going to let us know the integrity of the retina, the optic nerve, the optic radiations, and the visual cortex. With that being said, again, you do have a section in your handouts that has clinical correlates with both systems. We've talked about some of those today, but I would like you to look up the ones that were not discussed. You are responsible for knowing those for your quiz as well as your exam. If you're unable to find any of the information on these, feel free to email me, and I can help you with resources to learn more about those clinical correlates. I hope that you have a great week, and thank you very much.